2013 on the next slide. As you are aware, our Medicare physician fee schedule did stay at 0% for 2013. When we put this information together, we were instructed that we would be getting a 26.5% reduction for the 2013 Medicare physician fee schedule. This is just an example of showing you what the changes would have been if that reduction had come in. Please be assured that all services are processing under the 0% reduction rate. I do want to remind you, though, that due to geographical practice indices, we call them GPCIs, this information does change on a yearly basis, and so some of your services may have decreased based on the reductions or the increases to the GPCI. So even though we're staying at a 0%, you may see some difference in the reimbursement in some of your services. On the next slide, we're providing you with some of the new information for 2013. This is where you can go to and look, or the link to look at the current or the final Federal Register information regarding the fee schedule. We also have our fee schedules listed here in this link for Ohio and Kentucky Part B. We also want to remind you that with the final rule, there was a comment period up until December 31st of 2012. The provisions that are listed below have gone into effect January 1 of 2013, and that is 7% increase to payments for family physicians, also a 3 to 5% increase to other practitioners that are providing primary care services. We've also had an implementation of the physician's value-based payment modifier for provider offices with 100 or more physicians. And I'll go over this when we get to the physician quality reporting initiative. We've also had more updates regarding PQRS, e-prescribing, and electronic health records, and I will touch base on that. As CMS releases instructions to us, we will provide that information to you through our listserv. We want to remind you, too, that for the Medicare Part B deductible for your Medicare patients, this went into effect January 1 of 2013. Deductible is $147, a difference of $7 from 2012. There have been no changes in the beneficiary coinsurance for 2013. For additional resources and to direct your patients to information regarding Medicare changes, please direct them to the 2013 Medicare and You manual that is listed in the link there. Please remember that deductibles cannot be waived. We also want to remind you that for the physical therapy caps and exceptions, we will continue to reimburse those. The limit for 2013 is $1,900, and that would be for physical therapy and speech-language pathology combined, and then $1,900 for occupational therapy. Also, please remember that therapy caps are based on date of service, not on the date the claim is submitted or processed. We also would like to remind you on the following slide that claims-based data collection requirement for outpatient therapy services, we have to come up with new changes for that. We want to remind you that effective for dates of service on or after January 1 of 2013, CMS has implemented 42 non-payable functional HCPCS codes, 7 new modifiers, and this would apply to therapists in private practice, physicians, and nurse practitioners. This is basically collecting data on patient function during the course of therapy services to better understand patient condition and outcomes. These are only informational codes and modifiers. On the next slide, What Medicare is doing is that we are giving you a testing period, and this testing period runs from January 1 of 2013 through June 30th of 2013. This is where you will be able, this is giving you time to set up your system for these informational only G codes and modifiers. What you can do is make sure that your software companies, your billing agencies, your clearinghouses are aware that effective July 1 of 2013, these modifiers will have to be applied to any physical therapy services that are coming in for consideration of payment. We also have what we call an MLN Matters article. It is listed as MM8005, and it is available on the CMS website. Please familiarize yourself with these modifiers and HCPCS codes, because once July 1st comes, if you are rendering physical therapy services, they will have to be applied as informational only. On the next slide, this is what we are finding. If you remember, we started out with a phase, 3 phases of physical therapy services that went into effect November 1st of 2012. During this 2-month period, if you fall on one of the phases, you had to get pre-authorization in order for Medicare to continue reimbursing you for physical therapy services. We want to point out some of the documentation that we have received in our findings. And we just want to make sure that when you are supplying documentation, it's meeting medical necessity. An example of poor documentation was that documentation supports the patient is already at or being goes, but the provider is still requesting additional days of therapy. There is no use for continuation of these services, and there was no indication as to why it should be continued, so these services should not have been rendered to the patient. Documentation does not support progress to stated goals after prolonged therapy, or does not support continued need for skilled treatments. Always remember there has to be some type of follow-up to go over that care plan that has been set up for that patient to document whether or not the services being rendered are supporting this individual, or if they feel that something needs to be changed. There is no expectation that the continued therapy will improve the patient's condition in a reasonable period of time based on documentation. What we're saying is that documentation did not indicate any improvements or disapprovements as far as that individual's condition. Setting unreasonable goals. An example would be patient is ambulating at 200 feet. Provider wants to increase it to 300 feet without any justification or why the goal was increased. Please remember that when you're putting this documentation in, medical necessity is to support this. On the next slide, we have a couple more examples of documentation findings. I always like to remind our audience that these findings are just not with this phase pilot project that we're doing right now for Medicare and gathering documentation to show the need for physical therapy services and the extension of them, but it also are findings that we get from our review auditor. Maintenance programs are not covered if established after rehabilitative therapy has been completed. An example would be after the long-term goals for the rehabilitative therapy have been achieved. Incomplete documentation to support orders and patient certification for continued therapy. Please remember, we have guidelines. We also have a local coverage determination for physical therapy services. And when these services are not documented showing the medical necessity, then basically we are reimbursing you in error. On the next slide, we want to remind you that electronic submission of medical documentation is now being received in 2 ways. The old way, which would be all paper. This is where we send out a request for additional documentation via United States Postal Service, and in return, you would send that documentation back to us through the United States Postal Service. Now you have another option. We will send the request through the United States Postal Service, but now you can return that documentation through us through what we call an ESND database. On the next slide, we're giving you an example of how this works. You would receive the request through the mail. You would then have an option, again, either to return the information through the mail, or you can set up a database with the CMS database company, and they will take your documentation and then forward it to us. This is currently a random solution in providing your documentation to CGS, and on the next slide we are showing you exactly how it goes through. The documentation request letter is mailed out. You receive that information, you gather your documentation electronically, and then you would submit it to what we call the Content Transport Services, EMC through CMS, and then they will distribute that information. What we're showing you also is that the periodic contractor, the MAC, which is CGS, your Medicare Administrative Contractor, the third contractor, Imperium. You also see a question mark in that last building there. And that's just to let you know that eventually all Medicare auditors that are by CMS will be going through this new database and requesting documentation. In the near future, we will send our requests through this ESMD database, and you will only be able to return that information to us through this new database. For additional information, you can go out to the CMS website. There is a contractor that is handling this. They will check your software to make sure that you are compatible and can set up. There is no charge for setting this system up in connectivity with your systems. This is something that we're looking forward to because it at least gives Medicare the opportunity to see exactly how long it takes for us to review your documentation and the length of time that it takes for you to retrieve and get the documentation into us. It's also a step in going completely paperless. So please feel free to visit the CMS website and go to ESMD for more details regarding this. On the next slide, we would like to remind you, too, that there has been a place of service code update, and this will be going into effect on or after April 1st of 2013. The place of service setting in which the beneficiary received the first face-to-face service is where that service should be indicated for the professional component of a service, like, for example, MRIs, mammographies, anywhere where a patient is having a technical portion of the service provided in an outpatient or an inpatient setting. We'll give you an example where a beneficiary receives an MRI at an outpatient hospital near his home. The hospital submits the claim for the technical component, and then the physician reads or interprets the MRI, the professional component, in their office. That physician would submit that service as a place of service 22 for the professional component, not a place of service 11. This is going into effect April 1 of 2013. I'm getting so many questions regarding this, and just please remember that if the services are not rendered in that physician's office and there is no face-to-face, the services are rendered in an outpatient setting, then the place of service would be 22 and not the physician's office. This goes into effect April 1 of 2013. On the next slide, we're just basically reminding you that when a patient is an inpatient of a hospital, regardless, the services would always be placed to service 21. Okay, so please remember that. Place of service, when the service, the technical portion, is provided in a hospital setting, unless that patient is having a face-to-face during that date that that individual is reading that insert, then the place of service would be 22. If there's a face-to-face in the office at that date of service, then yes, the provider would bill a place of service 11. Okay. Medicare also issued out a new MM7631 or CR7631 on January the 25th of 2013, clarifying this information. There have been so many questions. On the next slide, we just want to remind you of the ordering and referring provider edits. In October of 2009, Medicare did roll out that they had set up an editing process on the ordering and referring providers. This editing process determines, basically identifies that the physicians that are listed and the non-physician practitioners that are listed in the two boxes here are the ones that are ordering and referring services. If it is not listed, one of the ones listed here on this side, then they cannot order or refer services. A good example would be chiropractic. They are not listed here as one that is identified that can order or refer by Medicare. So this means that if an x-ray is ordered by a chiropractor, the patient has to be reevaluated at the location where they have the radiology services by the appropriate either doctor or the appropriate non-physician practitioner that is listed, and then the service could, their information, their NPI, would go into ordering and referring field. On the next slide, we're reminding you too that in this edit, and it's basically identifying what happened in October of 2009. In addition to making sure that it is an appropriate individual who can order and refer, it is also checking to make sure that the provider is either a Medicare provider, and it is checking to make sure that that NPI is registered in the provider enrollment chain of ownership system. We call it pay codes. Now, for right now, you're just getting a message indicating that the provider is not either eligible or they are not listed in the provider enrollment chain of ownership system. And this is under phase 1. Under phase 2, what will happen is that we will not give you a warning. We will now start denying your service. And we just want to remind you of this because Medicare is going to bring in phase 2 in the very near future. We want to make sure that you're still checking your remittance notices to see whether or not you are getting a message in 264 or in 265 regarding the NPI number listed on your claim form that you submitted in. And again, what will happen is on phase 2, you will not get the message, you will get a denial. On the next slide, we give you an example of what the messages are, as I said before, in 264 and in 265. And it's basically identifying that the NPI, you can identify it on the 1500 claims form in Loop 17. I believe on the electronic billing, it's Loop 2310. Please check with your clearinghouse and software companies. But you do want to make sure that if you are getting those messages now, you're contacting that individual who ordered or rendered the services and letting them know they have to do a one-time 855 application so that they are incorporated into the PAYCO system. On the next slide, we're letting you know that once the services are provided to an individual and phase 2 will go into effect, before it does go into effect, we will give you a 60-day notification. We just want to let you know we hadn't talked about this in about a year of the holds that we've been putting on. But we are seeing notifications that it is coming back up. It's already started for durable medical equipment providers and home health and hospice providers. So eventually it will start up for your Medicare Part B claims. And again, we just ask that you continue to look at your remittance notices, electronically or paper, and check to see if you're getting into 64 or into 65 messages. And if you are working with a lab company, they may be getting that message and not paying attention to it, and we don't want them to be hold up in any delays of denials. The claims will be denied once this does go into effect. Okay. On the next slide, we're going to look at some of our Medicare incentive programs. For 2013, the Physician Quality Reporting System will continue, and if you are successful in reporting, you will receive a bonus of 0.5%. This bonus usually goes out the middle of October of each year. For additional information on the PQRS and the changes that are coming up, how to get started, measures and codes, and measure groups, you can go to the CMS website. Also, Medicare will be rolling out the value-based modifier program. It was passed through the Federal Register, and that information will be starting up very soon also. On the next slide, we want to just remind you that on the CMS website there are sample of measures and correct coding, as well as claim submission examples on the CMS website. It will show you how to participate, the reporting options that you have, the reporting periods, also the satisfactory reporting scenarios. These are findings that CMS has provided to the public based on some of the errors that they're bringing up from the database. All of this information is available in what we call the download information on the CMS PQR website. On the next slide, I talked about the value-based modifier, and the physician feedback value-based modifier program will provide a comparative performance information to physicians as part of Medicare's efforts to improve the quality and efficiency of Medicare care. By providing meaningful and actionable information to physicians so they can improve the care they deliver. CMS is moving toward physician reimbursement that rewards values rather than volume. And what we're looking at is, just like we had to, we weren't sure if the Medicare physician fee schedule will be reduced by 26.5%. Once this does go into full play, we will remove ourselves from the Medicare physician fee schedule, and you will be reimbursed based on the value of services that you provide to the patient rather than the volume. On the next slide, continuing with the value-based modifier, when will this affect you? This will start with physician groups of 100 or more that are eligible professionals who submit claims to Medicare under a single tax identification number. It will be subject to the value modifier in 2015, based on their performance, though, in calendar year 2013. All physicians who participate in the fee-for-service Medicare will be impacted by the CMS reporting quality data through PQRS, and by 2017 will be affected by the value modifier. So as you can see, it will be rolling out in stages, and we are starting with large groups. For additional information on this, please visit the website that is listed there, and for question and answers that CMS has received based on the value-based modifier. We also want to look at the e-prescribing. This incentive is reporting program that uses a combination of incentive payments and payment adjustments to encourage electronic prescribing by eligible professionals. If you are successful in 2013 in reporting, you will receive a 1% incentive. It's not available to professionals receiving the 2013 incentive from Medicare Electronic Health Record program. To be eligible, you have to report more than 10% of your charges based on the list of codes that's coming up on the next two slides. You can report through your claims, electronic or paper. You can either go through a qualified registry or a qualified electronic health record. The reporting periods are from January 1, 2013 through December 31st of 2013. On the next slide, we are identifying who is an eligible professional and successful reporting. And again, you have to report this 25 times or more by the end of 2013. The reporting limitations, incentives for eligible professionals who are authorized under the respective state laws to prescribe medication electronically. For a complete listing of qualified software, you can go to the State Board Pharmacy. That is listed, the web link here for Ohio and Kentucky. And again, you have to have a qualified e-prescribing system. At least 10% of your eligible professional Medicare Part B covered services must be made up of the codes in the denominator of the e-prescribing measure, and that is shown on the next slide. What we're indicating is that when you're submitting a service, one of the listed codes there's a face-to-face encounter, and there is a new prescription or prescription refill provided from a qualified e-prescribing system. You would submit in your reimbursable E&M service or face-to-face encounter service that is listed there. We call it the denominator code, in addition to the G8553. These services have to be payable. If we do not allow the service that is listed under the denominator section, then you will not get credit for that G8553. So please remember that this information does have to come in. On the following slide, we want to point out to you that in 2013, if you were not successfully reported the e-prescribing code and you did not have a hardship exemption, you will receive a 1.5% reduction in any of your Medicare fee-for-service reimbursement. And this year will continue throughout the full year. If you received a notification from CMS, and these letters were mailed out the last week in December, you should have received them no later than January 1st. You had until December 31st to report your hardship to CMS through their database. They would have reviewed that and notified you electronically on whether or not that 1.5% would have been waived. Again, you should have received a letter. We also want to remind you, too, that you do have to report this information in order to avoid the reduction. The first 6 months, you have to submit in at least 10 claims with the G855 code, along with the denominator code, table denominator code, to be waived from that. Medicare is now gathering this information from 2012 and 2013 to see whether or not you will have a reduction for the upcoming year also. This will, we are also looking at reductions for PQRS. So please make sure you do go out to the website to see what the pay adjustments will be affecting you starting in 2015. On the next slide, we are looking at how to get assistance. If you have questions or concerns regarding hardship or e-prescribing questions, you can contact Quality Help Net Desk at the toll-free number that is listed on this slide from 7 a.m. to 7 p.m. Please remember they do not answer questions regarding claims processing. However, if you have a question regarding a hardship or you want additional information on this program, you can contact the CMS Help Desk. On the next slide, we're looking at the electronic health record, and this is part of the American Recovery and Reinvestment Act of 2009. This is basically where the law provides opportunities to improve health and care through health information technology. We call it HIT. It also promotes electronic health records through incentive programs for the meaningful use of certified electronic health records technology. To be eligible to participate in this, we provide you with a little bit of information on the following slide, where you have to be an eligible professional in order to qualify for this incentive. You can go out to the CMS website to see how you would register for this. And if you have questions regarding the Electronic Health Record Incentive Program, you can contact the Information Center at the toll-free number listed there. But CMS does have the registration on their website, and you can go out there to register and set up. We provide you with a little bit more information on once you are registering for this information on the next slide. And these are just the requirements. Here's a little bit more information also, that you will have to be one of the listed eligible professionals, and we provide you with the listing there. You also, again, you do have to register the EHR webpage. You have to have an active MPES account. That's your National Provider Identifier Number. You have to use certified electronic health technology. You have to be enrolled in the provider enrollment chain of ownership. is where you have to do that one-time $855 if you are not in pay-codes already. So again, more information is on the CMS website. On the next slide, we're providing you with information. If you're successful in reporting, this will be running all the way through to 2016. And if you're successful in reporting each year, this is what the maximum you can receive regarding this reimbursement for this incentive. We do encourage early registration, even if you do not have systems in place at this time. It will ensure you are enrolled in the CMS systems to receive incentives timely. It's also showing that when Medicare starts the reductions for not participating in this, that this will be one of the things that will waive your hardship. Eligible professionals may participate in Medicare or Medicaid, and you can switch once during the reporting period of 2012 and 2014 from either Medicare to Medicaid. So again, for additional information, please visit the CMS website. There's full detailed information on that website and all of the system qualifications. And the timeline, there is a fact sheet also for the electronic health record. I do know that there has been quite a few changes as far as how CMS is accepting this information on your meaningful use. So again, please visit the CMS website. Let's look at some of our ongoing Medicare initiatives. Provider enrollment revalidation. We do want to remind you that starting in March of 2011, Medicare has instructed all contractors to do a revalidation of all Medicare providers. And this will last until March 23rd of 2015. You cannot do the revalidation until you have been notified by CGS. So please do not try to do an early revalidation. We're notified by CMS. And on the next slide, we show you that once we're notified by CMS, they send us a list of NPIs. When we receive that list, we mail out the revalidation letter instructing you that you have 60 days to get the 855 application back to us, either electronically or paper. And it does, your notification will be received in a bright yellow envelope. So please let your staff know this. On the next slide, we are pointing out some of the factors as far as information on revalidation. And we are finding quite a few providers who are not completing their 855 applications completely. So we've provided you with a tool that you can go out on our website and bring up the information on how to complete the 855. This is very important. We want to remind you that if you haven't notified us of a mailing address change and that envelope comes back to us, that deactivates your Medicare enrollment, and you have to start all over again with a brand new application. So please, you want to be on the lookout for this information. CMS on their provider enrollment webpage, they have a revalidation section. Once you bring up that revalidation section, they have a listing of each time all contractors have mailed out letters to providers. They provide you with the date. If your name is listed there and you did not reply to that notification, it will also show that you've been deactivated. So if you are not receiving payment for your Medicare services that you're submitting, you're getting a denial that you've been terminated or you're not effective for these services, your first step would be to check with the CMS website under revalidation to see if your name is listed there. If your name is listed, that means that you received a yellow envelope. And again, you have 60 days to get that information back to us. On the next slide, we want to give you just some of our top revalidation development reasons. Now, Medicare does instruct all contractors to have some type of identification in process through provider enrollment. Our process is to have either a copy of your driver's license or a current passport. Please remember that when you're completing your revalidation application or any type of Medicare provider application, when it's coming into CGS, you have to supply us with either your driver's license or current passport. If it is not received, then we will not be able to process that application. We also want to remind you that if you have any types of documentations with the Internal Revenue that you're submitting in, they call CP 575, or an IRS documentation, please make sure it is attached to your application and make sure everything is matching that documentation. If it is not matching, you do want to contact the Internal Revenue Service to make sure your records are updated and they provide you with new copies of information. On the next slide, we're giving you additional information of some of our top reasons for missing information, and it does go back to information as far as what's being completed. Also, you want to put a correspondence telephone number. When we finish up your application, we do make a contact phone call to that number just to verify that that individual is practicing at that location that is listed there for the contact information. Please let your staff know that we're calling. Let your staff know that you have new employees coming in or applications have been completed. If you cannot identify that individual that we're calling on, we have to stop the process of that. Also, we want to remind you, too, the name of the Medicare identification number and NPI of each group has to have an active of the assignment affiliation that is required. We also need a voided check or bank letter so that we can set up your electronic funds transfer if you are receiving a paper check. So please remember, paper checks are no longer acceptable. We cannot, we are trying to make sure all of our records are updated. So if you are receiving a paper check, you get a revalidation, make sure that you put a copy of your voided or bank letter so that we can set you up for electronic funds transfer. The other information, too, practice locations. We need to, you have to identify all of your practice locations, and that has to be on the 855. We also want to remind you, too, that there are some providers who may have to pay a fee to have this revalidation process or any changes to an 855 process. Medicare started this in March of 2011, and the fee is currently $522. It may go up for 2013. We have not been notified as of yet. But if you do qualify to pay that fee, you can find that information on the CMS website. We just want to remind you, you don't want to put your payments at risk. Make sure that once you receive this yellow envelope, you want to act immediately and make sure that your revalidation request is sent back into CGS. Again, you don't want to cause any delays in the processing of your services. We also would like to remind you that CMS is providing a tutorial training, and you can get CEU credits for this, and it's called the CMS Medical Identity Theft Web-Based Training. And it is a free course that providers can take so that they can identify the different types of theft within the Medicare program. And again, Medicare is promoting this. Please visit the Medicare Learning Network. You can register. It takes about 35 to 45 minutes to take this course. Once completed, you will receive a certificate, and this can be submitted in for CEU credit. We also want to remind you that for ICD-10 diagnosis coding, this will be going into effect October 1 of 2014. The ICD-10 diagnosis codes will be replacing the ICD-9. For additional information on these changes, we provide you with a web link. Now, the next couple of slides, and I know that time is a presence right now, we basically are giving you information on planning for this change. Before you know it, October of 2014 will be here, and we don't want you to get caught up in the delay of not being prepared. So the next slides are basically helping you and getting your staff prepared in addition to your software and everything that is needed so that you can accomplish this smoothly without any delays in the processing of your services. I always like to remind you that when the ANSI 5010 came out last January of 2012, and when it went into effect permanently July 1 of 2012, that's one of the first steps of the ICD-10. So please make sure that you do look at this information, make sure that your staff understands the major change and how it is going to have a major impact on you. You never know. We may start accepting this information prior to October 1 of 2014. So we want you to be prepared for this just in case we do. Our systems are ready to accept this, and we will be sending out notifications when we will be accepting ICD-10 in addition to the ICD-9. So this way you'll be prepared to know this information. And again, CMS has provided a lot of information. They're working very closely with the AAPC chapters in providing training material, not just for physicians and practices, but also for their contractors. We'll be going through the same training. Okay? So I'm going to go ahead and let's look at our comprehensive error rate testing. This is another initiative regarding the Medicare program, and the CERT program basically was established to monitor the accuracy of payments made by Medicare fee-for-service contractors. This is CGS and other contractors. The goal is to protect Medicare trust fund and promote correct coding. With the outcomes of our errors and notifications, we use this to identify educational needs. Hot CERT issues right now are signatures and medical records, evaluation and management services, and documentation errors and omissions. On the next slide, we're just letting you know we do follow the CMS guidelines for signatures. We provide you with examples of acceptable forms of signature. It has to be a legible, handwritten signature, okay, that will be accepted on the medical documentation. If it's not legible, you do want to use an attestation statement that is available on our website, or include a signature log with your documentation. This is where you will have the physician sign it, and then next to that signed signature, it will be typed out to identify that the signature is not legible. We also accept electronic signatures. It should contain the date and time stamps and include printed statements, for example, electronically signed by or verified by, followed by the practitioner's name and preferable professional designation. It's not mandated under Medicare to provide the professional designation, but if your system is set up to put that, that is fine. Digitized signatures are also acceptable, and this is really an electronic image. Is the individual's handwritten signature reproduced in its identical form using a pen tablet. It is not a stamp. It is through a pen tablet. So we do want to remind you of that. On the next slide, we're letting you know this is basically information that CMS has provided, guidelines for acceptable signatures. You can either go through the medical CMS MLN Matters article, MM6698, or the transmittals that CMS provides, and that would be CR6698. There's complete guidelines regarding unacceptable signatures. I always like to say that we do monitor the time, the signature of the documentation, and the date. So late signatures are not acceptable, so please remember that. On the next slide, we're looking at evaluation and management codes. We just want to remind you that you should be submitting the most appropriate level of E&M service based on your documentation. Upcoding and downcoding are both counted as billing errors. And we want to remind you that new patient visits ensure that the patient has not been seen by the same specialty within the same practice in the past 3 years. Know the guidelines of evaluation and management codes, and we are still using the 1995 guidelines in addition to the 1997. 1997 basically is more geared to more specialty-focused direction. Both sets of guidelines are available on the CMS website. And on the next slide, we're providing you with some information regarding insufficient documentation. Medical necessity must always be clearly documented in the patient's medical record. You can still follow those guidelines that are listed in the 95 and 97, but if we are not pulling medical necessity from your documentation, that will not be acceptable. So please just remember, medical necessity always falls in first. When documentation is requested, please remember to send all relevant information, including orders, plans of care, and etc. If documentation is missing a signature, have the provider complete the attestation statement and include it with the documentation. We do not want you to sign that documentation because it's late. So please remember, you attach an attestation statement. On the next slide, we just want to remind you that the CERT contractor has provided us what we call a CERT identifier tool. This is where you can take your CID number, go out to our website at CGS, and go under Tools. And once you're there, you can bring up the CID tool, enter your CID number or your NPI, and it will give you the status of your review. Either it has still pending or it's been completed. If the review has been completed, and if there was an error found, it will be giving you detailed information regarding that error. On the next slide, this is our CGS operational updates. And we just want to remind you that when we send you a letter asking for additional documentation, the letter has to be returned via mail. It cannot be faxed in. As I explained earlier in the beginning, you can send it via mail or you can go through the CMS database to send the documentation. We also want to remind you that when you're submitting that additional documentation per that request, that the documentation is signed. If it's not signed, then the attestation statement must be attached to that documentation. We're seeing a lot of our notifications being ignored, and they're not being submitted in upon our request. This is very important for us to have this information. We also want to remind you that you do not fax documentation into us when we have mailed out this request. CMS requires that once this letter is sent out, we have 45 days to receive your documentation. If it's not received, then it could cause for denial. We're also asking that you do not resubmit the claim until you receive an initial determination on the claim. If you submit the claim and that claim is still pending or reviewed based on that request for the documentation, it will result in a duplicate denial. So please, before sending in a new claim, if you've asked for additional documentation, call in to see if your claim is still pending. If it's still pending, do not submit a new claim. On the next slide, we just want to remind you, if you're submitting paper Medicare secondary payer claims, the complete primary explanation of benefits must be attached to the CMS 1500 claim form. When submitting that information, make sure that the primary EOB letterhead, that will be the name of the insurer, the claim information is matching the information on your claim form. Claim adjustment reason codes are also listed and identified from the primary. They may be different from Medicare's reason codes. And if you don't have them listed, provide us with a glossary of the primary reason codes so that we can understand what their decisions were. On the next slide, we want to remind you that our overpayment recovery, we started when we have a request for an overpayment sent out to you. They are being mailed in light blue envelopes. This will assist in identifying that you have some time-sensitive information in the envelope. So please let your staff know that when a blue envelope is coming in, that is what we call a demand letter, and we are asking for a refund. On the next slide, We just want to remind you that once you do receive requests for an overpayment, you may request that the refund be done by what we call a immediate offset. You can fax this information in to us on the immediate offset form. Once we receive that form, this is where you're not sending any money in. You're just asking us to withhold that money from any upcoming payments that Medicare is to pay out to you. Medicare has provided guidelines under the MLN Article 7688 if you have questions or concerns regarding how to complete those forms. On the next slide, we would like to remind you, too, that a reopening form is available, and this is when you are writing in for a reopening, or you can do a reopening by telephone. I do want to remind you that when you're doing a reopening, you're indicating that you want to correct a simple error. This would mean that you want to apply a 25 modifier, a 59 modifier, something that our system is not going to have to go through coverage and need additional documentation to support medical necessity. If you're applying a 24 modifier, this would not be a reopening. So we are asking that, you have to make that determination whether or not it's a reopening or a redetermination. If it is a reopening, you can either do it by phone or you can do this through the form that we have listed and mail in. On the next slide, we're providing you with just a cheat sheet letting you know how a telephone reopening can come in or a written reopening. This is something good for your staff to have when that decision is made that we need to make a correction on the claim. So this is just a tool that we provided for you in our packet so that you can keep on hand. On the next slide, we're letting you know that we now have a new redetermination form. This is where you are requesting an appeal, and you're going to provide us with additional documentation to support medical necessity. Everything has to be completed on this form. Please make sure you send in your supporting documentation, and as always, check that signature. If the signature is not on that documentation, provide an attestation along with this form. Make sure the form is signed by the one completing the form. First and last name has to be listed. To get a copy of this new form, you can go out to our website, and once on that website, you can just select forms, and this form is available to you. On the next slide, we're letting you know that our customer service is available, and there are 3 levels of customer service. The first level is basically for easy questions or answers. Maybe you're checking to see if that claim is still pending. You may want to know where to find certain information from. That will be what we call our Tier 1. Once your call has to be escalated to a Tier 2 or Tier 3, that means that information may have to be a callback or research needed. But we do want to make sure that you are utilizing our customer service area. The hours of operation are listed here on this slide, and we ask that you, for anything pertaining to status, you go through our IVR or you use our MyCGS. But we do have customer service available for you. On the next slide, we're giving you information regarding our forms that we have out on our website. I just went through 2 forms, and that was one regarding the reopening, and the other was the redetermination. But all of our forms can now be completed online. You can print them, and then you can save that form into your system, into your own file. We just ask that when you go to do a new form, go back to our website and pull up a new one. This way you have the most current form. But once you complete your form, print it and save it into your records, and then that way you will have a copy of that without printing it and making a photocopy. So all of our forms can now be saved onto your own computer once they are completed. On the next slide, we just want to let you know that 26.5% of our Part B providers are still receiving paper remits. If you're billing electronically, you should be pulling an electronic remittance advice notification. You should not be receiving paper. If you need assistance on how to set up the electronic remittance advice access, you can contact our EDI help desk at the toll-free number at the bottom of the slide. Also, you can, once you get the electronic remittance advice notification, it's not reader-friendly. You can download it into the new software that CMS has, and it will make that remittance notice look just like the one you receive in the mail. So please take advantage of these tools that we have, and it will assist you. The other advantage of this is that once your claim has gone into a final location of payment, you can pull your electronic remittance advice and start doing your bookkeeping. You don't have to wait until that paper ER remittance comes in the mail. It doesn't give payment, but it will show what is going to be paid, what has been approved for payment. So this usually happens within about 48 hours once a clean claim comes in. We still have to hold the claim for 14 days, but it does assure payment. Once it gets into the final location, we will not be taking any money back. If there is a withholding, it will be done before it gets into the final payment. On the next slide, we're basically showing you our website and all of the information I just talked about, how you can get to our website for forms, all different types of documentation, coverage information. This is where you would go. Select Ohio or Kentucky, Part A, Home Health and Hospice. Everything is listed here for you to get familiar with CGS information. On the next slide, we're asking that if you haven't already done so, please join our listserv. In this presentation, I talked about the 60-day notification of when it will go into effect for the ordering, referring. This is how we're going to notify you. Whenever something is to be released throughout CGS or from Medicare, this is where we will send it out through the listserv. We don't try to overwhelm you with a lot of emails. Usually they go out in the late afternoon, no more than 2 per day, but you will get information of updated information. On the next slide, we're providing you with our educational information. I know that today we are extending, I do apologize for our time, but if you would like to join in any other workshops or seminars, or you want to ask the contractor teleconferences, you want to request a speaker, online education center, we have a lot of tutorials out on our website. You can go out to the links that are listed here for Ohio and Kentucky. And this is for J15. This will be for Part A and Part B also. On the next slide, we are basically letting you know that we are on Facebook. Whenever we push out a listserv, we also post that information on our Facebook. Please remember, though, that if you do key in any comments or remarks on Facebook, it is public information, so you want to be careful and make sure no PHI information is listed on Facebook. But it is a helpful tool to keep you informed regarding Medicare updates. On the next slide, we are providing you with I'm sorry, it looks like we're freezing up. Okay. I do apologize. Can we go to our next slide, please?
Vanessa, is it advancing? Vanessa,
hello?
Are you advancing at all?
No, I'm not.
Okay.
I'm still on the Facebook.
Now I'm afraid the damn thing, is maybe just an hour long. Let me go into my office. Let me go to one of the other desks here and see if they're able to see anything different.
Okay. Can everyone see my screen? I'm going to bring up something, okay?
We can see Facebook screen, yes.
Well, we're operating it, so the meeting may have shut us down.
Oh, because it was only an
Where
hour.
where else is it being shown here? Just in the Annie's office? Well, Annie's actually did it. She signed on just to listen to it individually. So I heard she held the process for me to give it to her.
Vanessa, the people are looking at the Facebook screen. I'm surprised you're not at this point.
Okay. Can you give them access to my screen? Now.
Yeah, I think I can.
Okay, try that. Can they see mine?
Oh.
Does that help, Vanessa?
Yes.
Annie said you had it at the screen that you had before that.
Are they able to see my screen?
Hang on a second.
One webinar. Organizer that, presenters that. Waiting to view Vanessa's screen. That's me.
There's no more page forward.
It will show up in a moment.
Yeah. When you whip your mouse down,
You have to have a cursor on it.
Or give her.
Yeah, it didn't do any good. There's language associated with that. Are you sure you want to make it a presenter again? And
No longer the presenter, so that should give her.
but I can't see her screen. You know? I'm sorry, Vanessa. I can't seem to get you up as presenter so we can see your screen.
Okay. Well, everyone, I'm going to continue on. It's only about 3 more slides. Is that okay?
Yes, please.
Okay. And I do apologize, everyone, but on the next couple of slides, it's information regarding my CGS. This is a free web portal tool that we have released in August of 2012. And basically, when you register for my CGS, you will have access to beneficiary eligibility, claim status, ability to view and print your remittance notices, and you'll also have access to your financial information, including the amount accrued to pay and the last 3 checks that you will be entitled to from Medicare. We have a video library for resources for my CGS. And this is an excellent tool to register for. You can now have 2 administrators, and those 2 administrators will be able to assign individuals within your office or your practice who can have access to what. This is a great tool for your front desk when they're doing registration. They can check to see just what type of Medicare insurance your patient has. It could be a Medicare Advantage plan, whether or not Medicare is primary or secondary. This information will give you access to that. The other thing I want to point out, if you're billing electronically, very soon, if I'm not mistaken, it will be starting, I think, April 1st, or if not, has already started. Medicare is removing the eligibility portion from your electronic billing. This is where you would send in your batch of claims, and we would send you information that the patient's number was incorrect or the name was incorrect. Well, we will no longer be able to provide that information to you. It's part of the 277, 276 message. Due to PHI regulations, we have to remove that. So this tool will be very helpful in making sure you have accurate information. And as always, please ask for your patients' copies of Medicare cards so that you can verify their name correctly as the Social Security Administration has it listed. But again, this information is available to you. If you have questions on how to get signed up for it, you can contact our EDI help desk, and that information is in the packet that you'll be receiving very shortly after this presentation. And for that rounds up this presentation. I do want to acknowledge, I appreciate everyone's patience. I know that webinars are changing so much that we do have a little bit of technical difficulty. But I will go back to the screen, and I know that we only scheduled for 1 hour, but if someone would like to submit questions or concerns that they have regarding CGS, or if they need some assistance, please feel free to email me. My email address is Vanessa, V-A-N-E-S-S-A, .Williams at CGS Admin, A-D-M-I-N, all one word, cgsadmin.com. I always ask that you put a red flag so that it does get my attention. I do get hundreds of emails a day with Medicare updates, but we are available here to assist you. If it is something that you can find on our website, we do ask that you go that route, but maybe you've become a little bit impatient and you want some one-on-one assistance, or you can go directly through Stan, and he will make sure that I get your questions or concerns. And Stan, with that being said, I'm going to turn it back over to you.
Great, guys. And again, it was a little halting today. I apologize for that. We do have this presentation recorded, and we'll give you everyone that was signed up for this a link to be able to review this at a later date at their leisure. So if that helps out at all. And again, do thank you all for your attendance here this afternoon. With that, we'll conclude the webinar. Thank you.
Thank you, everyone. Bye-bye.
Bye. Thanks, Vanessa.
Mm-hmm.